Hello, everyone. This is Wigdan Omer, and I'll be presenting my second peer review and critique. The study I've chosen is titled Systemic Review of Health Economic Evaluations focused on artificial intelligence in healthcare, the tortoise and the cheetah. The tortoise is the metaphor of health economic evaluations, and the cheetah is the rapidly evolving AI. So this review examined 20 studies of AI applications in healthcare, mostly in medical image analysis. These studies were published in PubMed and Scopus from 2016 to 2021. Two methodologies were used, Consolidated Health Economic Evaluation, Reporting Standards, CHEERS, and Phillips Checklist. Economic evaluations in these studies were cost minimization analysis, cost effectiveness analysis, and cost utility analysis. The study concluded that most studies lack sufficient evidence for rationale of modeling choice, comparative effectiveness, health technology assessment, heterogeneity and structural uncertainty, and validation. So the relevant concepts in these studies are the three health economic evaluations. Cost minimization, as we know, compares two interventions that have the same type of outcome in terms of cost. It assumes that both outcomes are identical, and it compares the cost of one against the other by just taking the difference. And it's expressed in monetary units and preferred intervention. Other evaluation technique is cost effectiveness analysis, and this compares interventions of the same type of outcome, but different effects or different values and different costs. They're calculated as a ratio between difference in cost and difference in effect, basically the ICER, the incremental cost effectiveness ratio. And it's expressed as cost per natural unit. This natural unit can be any health effect. Utility analysis is used for cross-disease comparability, and it compares how in utility units. Most commonly used utility unit is the QALYs, which is quality adjusted life years. This is a sample of the studies that are there. As you can see, the type of health economics are mentioned here. The intervention versus the comparator. Most of the interventions are AI augmented image analysis. Comparator are just the conventional methods used, traditional methods, and it's from different perspectives, either the payer perspective, who are the insurance companies, hospital or caregiver, societal. And then we have the discounted rate. Those with the asterisk sign means they're not reported. The discounted rate ranged from 3 to 3.5. The time horizon was mostly a 12-month period. And then we have the outcome measures. Of course, if you have a minimization analysis, your outcome is going to be in terms of preferred intervention. If it's in cost effectiveness, it's going to be outcome of the cost per effect or per quality. And if it's a utility, it's going to be in qualities. So the review used two methodologies, as I mentioned, CHEERS and Phillips list. So what is CHEERS? CHEERS is Consolidated Health Economic Evaluation Reporting Standards. And it was basically endorsed by economic and medical journals in 2013. And it set guidance or criteria for reporting and methodology used for any economic health publications. It lists 24 items, and it checks if they're complete, then the study is given a point for it. And then for those incomplete or absent, they're scored 0, and the total scored is then counted as a percentage. It focuses on cost effectiveness assessment and cost utility and state transition models. The goal for CHEERS is to improve quality of clinical trials and health outcome research, enhance more consistency and transparency, ensure patient and public involvement in health service research. The CHEERS is basically beneficial for decision makers, funding agency like the FDA, insurance companies, and international organizations. Here's the list of 24 items of CHEERS. Abstract, introduction, target population, setting location, study perspective, comparators, time horizon, discount rate, choice, health outcome, effectiveness measurement, validation, estimating resources, currency and convention, model choice, assumptions, analytical methods, study parameters, incremental outcomes, characterizing uncertainty and characterizing heterogeneity, discussion, funding, and conflict of interest. In average, the study scored 66% CHEERS, and the most lacking thing was characteristic heterogeneity, and analytical methods were not as useful or as accurate as there should be. The next methodology was Phillips checklist. It's only for model-based studies. Out of the 20 studies that were reviewed, only 9 had model-based studies, and they use either decision tree or Markov modeling. Decision tree is just a simple decision tree structure, and most of them had only 2 to 3 branches. And it compares the new intervention against the old or standard one, and compares the qualities or qualities. Those studies who use decision tree reason that to trade off between interpretability and accuracy and simplicity of the model. In terms of simplicity, both models are the decision tree and Markov are considered simple models. The Markov tree modeling is different. It's almost like a cyclical relationship. It's time-dependent transitions. The most common transition is between asymptomatic state to progressive disease and then to death. An asymptomatic patient can progress to disease, and when a person is asymptomatic, there is a certain percentage or probability that he will become diseased or even progress immediately to death. And then from progressive, there is a possibility to recover and become asymptomatic or progress to death. And of course, if you're dead, you can't progress the other way around. It was particularly chosen because this allows incorporating recurring events and time-dependent transitions. So here is the complete table of the Phillips checklist that was provided by the review. You can see that these are the 9 studies. And this is the type of model, decision tree, Markov. One of them had used both decision and Markov. This is the health economic evaluation type. We have cost effectiveness, utility, and minimization. Here is just explaining what the model was about or included, and then the time horizon. And the sensitivity analysis, they mostly use univariate and probabilistic sensitivity analysis. And outcome, depending on the type of economic evaluation, is listed. If it's cost effectiveness, it's going to be listed as in ICER. If it's utility, it's going to be in qualities. And if it's minimization, is going to be in terms of the preferred intervention. When they say intervention dominant, that means it's both cost-effective and quality-effective. It has better outcome, and at the same time, it costs less. So the review concluded that there were limitations in these studies, and these limitations may be attributed to the choice of health economic methods. It claims that the model types used were relatively simple, which are the Markov and decision tree, and therefore they're unfortunately both quantitatively and qualitatively limited. The fact that only few assessments are published, often are of suboptimal quality, may severely hinder adoption of AI into clinical practice. The other note in the conclusion is that there is abundance of existing AI innovation and inspiring initiatives, but clinical practice and policymakers are asking for suitable methodologies and outcome measures to assess the added value. The most important thing here is, what is the added value? It should be clearly stated and properly calculated. The limitations of the study is that it had only 20 compared to the published. For example, in 2019, there were over 120,000 AI studies published, and nearly 20,000 HEEs in 2016 alone. Also, the review excluded all non-English publications. In my opinion, the review didn't exactly show what is the best alternative. It did critique the current HEEs that are used, but it didn't provide any suggestions or recommendation for alternative methods. Okay, thank you for listening, and that's all.